EM board bombs.
Welcome back and good morning. Good morning, sunshine, Dr. Whiskey Coon. Waking up on mountain time. Greetings from Eastern time as well. Afternoon, Eastern time. Dr. Whiskey Coon back with us again. Integral member of the team. Thanks for joining us. You can follow us on where?
At
All the
EM Board
socials.
Bombs.
All the socials.
All the socials.
All the socials. If you don't like Twitter anymore, that's cool. We got Instagram. We got
Threads.
Yeah, keep going. I can't name them all. Facebook. We got them all the socials. So check us out. EM Board Bombs. Same name, same place, everywhere. And then our website, emboardbombs.com. We have what? Amazing handouts. Airway module.
Tons of handouts.
What else do we have? Tons of free podcasts. Over 250 episodes now. Insane. And our only sponsor, of course, Emergent Medicine News. Thank you to them. Check them out. For each 10 to 15 minute episode, we learn amazing EM content.
Jam-packed.
So let's dive into it. Got a 55-year-old male presenting to the ED because his neighbor's cousin's chiropractor, who also runs a esthetician store, is that what it's called? Or massage parlor, as well as an herbal alternative health clinic next to the chiropractor office. Anyway, he decided to check his blood pressure at that chiropractor's office, and it was 200 over 110. Now, the chiropractor tried administering some herbals as well to see if that would help. Also ordered some, I didn't know chiropractors could do this. They ordered some labs. They ordered some ACTH and cortisol. They like to do that a lot. They did some deep brain stimulation as well, too.
Oh, my God.
And acupuncture. Anyway, all that stuff happened. It didn't really change the blood pressure. He feels fine, except for a mild headache that he thinks is from binge watching conspiracy documentaries the night before, mostly Ancient Aliens. He's worried because he thinks, quote, the machine beeped real loud for the blood pressure, and Dr. Google said, quote, his brain is gonna explode, end quote. Blood pressure's 210 over 115. What's your best next step? Choice A, IV hydralazine. Choice B, place the patient in a separate triage room or hall bed, reassess in 30 minutes. Choice C, IV labetalol. Choice D, oral clonidine. Don't hold us in suspense any longer, Dr. Siskikoon.
Well, as I like to do with my patients who have, conditions where their brains are about to explode. B, place the patient in a separate triage room or hall bed and reassess them in 30 minutes.
That sounds very interesting.
The correct answer.
That's actually the correct answer. Hey, before we get into that, tell us all the things about EM Rapid Bombs we got to know about.
Yeah, EM Rapid Bombs. It's the best. If you have not signed up for this yet, I don't know why.
You're silly.
What are you waiting for? Do you need me to send an addressed invitation to your house? I might do it. Just let me know, because
send a greeting card.
We have so much content on there. If you think we have a ton of free content on our website, then you are just going to be blown away by how much content we have on EM Rapid Bombs. We have twice as many episodes. Mm-hmm. They cover like a range of topics. Everything that we have on EM Board Bombs, we go into depth on EM Rapid Bombs, but they're short episodes. They are even more jam-packed with just what you need to know for how to pass your boards and everyday life. You can incorporate them into your daily life. You can listen to 2 episodes a day, and you would have nearly a year's worth of content.
Incredible. Yeah, check it out. Yeah. Each episode is like less than 4 minutes. We cover amazing content. I just launched one this morning on neonatal cyanosis, central versus peripheral, and talking about the best next step, how to manage that. If you know the answer, that's great. If you don't, check out EM Rapid Bombs. Even if you know the answer, talk about a great review, less than 4 minutes. So yeah, check it out. Cool. So hey, we're diving into this topic today that we're just giving an overview because most of these topics have been covered extensively on EM Rapid Bombs. So we want to give you a nice overview of defining when to aggressively treat blood pressures and when not to. I feel like this is such a big pet peeve among emergency medicine doctors. If you obviously read the literature, I think most emergency medicine doctors never want to aggressively treat asymptomatic blood pressure, but we're like conned into it by like primary care doctors and other like specialists upstairs, and then unfortunately, very concerned patients and families were all kind of like, okay, fine, we'll treat the numbers, and we get it. We get it. We just trying to discharge the patient. But we'll teach you a new approach, and definitely what the test wants you to do, because the test does not want you to do things that just please people. They want you to practice evidence-based medicine. So why don't you get into some definitions here and kind of distinguish what's real, what's fake?
Yeah, and what's fake is Dr. Google saying this man's head is about to explode. Yes. It's not why I put him in the hall.
Yes.
If your patient's head's about to explode, actually, please don't put them in the hall. It'd be a terrible thing to do to your janitorial service. So here's the deal. Sorry.
It's that night shift
People
humor.
walk in. Yeah. I did just wake up. People walk in with really high blood pressure all the time. It's, it's the ED.
It's America.
But most of these people, and it's America, yeah. Most of these patients are not in immediate danger from their really high blood pressure. 180 over 120, yes, that is high. Of course, that's not great for them to be walking around with every day. Having a mild headache, that's a common thing we see in patients. But someone with a normal neuro exam, not having chest pain, not short of breath, not having any symptoms, walking around, walkie-talkie, moving all their arms and legs, seeing fine, it's not an emergency. It's an emergency room. So what do you do, Dr. Briggs?
Turning the tables. You don't aggressively treat these people. You don't aggressively lower their blood pressure. This actually can be harmful. So hypertensive urgency is a term that it's semantic, I know, but I just don't like it because it implies that you have to do something quickly. And I don't like telling patients that either. I think it's fake news. Let's be real. It's fake news. Here's the deal. People, like you said, walk in all the time and they have that high blood pressure. But the thing here is that you have to do is you need to have them relax in a quiet room. I know that's silly. A room is a luxury in the ED. It's real estate. But having them sit somewhere, even just in the lobby if you can, for just 30 minutes. They just walked in from the parking garage or an ambulance brought them in. They're stressed. They're worried about their blood pressure. They probably took it 50 times at home or at the pharmacy or the grocery store where the cuff hasn't been calibrated in how many years. So yeah, sit them down for 30 minutes if you can, even an hour, and just relax. Tell them just to sit down. Don't get up at all. I guarantee the blood pressure will go down. It's just... Have you done this personally? Do you do this too?
Yeah, I set it to take it later, and then I leave the room because I'm going to stress them out. The nurse is going to stress them out. Like anybody else being in the room is going to stress them out. Yeah. Yeah,
it definitely helps. And then what you're going to do is discharge with outpatient follow-up. Again, these are patients who are asymptomatic. This is the person that classically, hey, I check my blood pressure randomly, and I have no history of high blood pressure, or maybe I do just have high blood pressure, and my blood pressure is really high. This is so important not to just push IV meds. The only urgent thing here about this is make sure they see a primary care doctor. Now, there's some argument, and we're not going to get into it here because it's just nuanced and it's actively debated in emergency medicine. Do you get labs on these people to check for, screen for chronic kidney disease? Do you do, other tests related if they have heart disease history? The evidence is poor. It's like level C evidence, and we're not going to get into that. The test is not going to want you to do that. The test is going to want you just to discharge them. Can you start them on an antihypertensive? Sure, that's a whole different discussion. You can if you want. There's, again, nuanced discussion on that. But the test answer and what they're looking for is plus or minus prescription for amlodipine or something, and then discharge home. We're not going to get into the particulars of what you prescribe. It's a discharge home, discharge outpatient follow-up. That is it. So what about hypertensive emergency? This is obviously real, but I feel like this term also gets abused a lot because you walk into a room, I'll have a resident or med student see someone, they walk out and they say, hey, I think they're having hypertensive urgency. What from? Because obviously hypertensive emergency is a chief complaint, really. There's so many causes and the treatment's different too. So why don't you dive into, when the blood pressure being high is actually dangerous and then list some I would call the hallmark signs and symptoms of chief pathologies, just naming off these chief pathologies.
Hypertensive emergency is the blood pressure reading plus the end organ damage, like Dr. Briggs just said. So it's actually dangerous when you have the end organ damage. So of the brain, that would be like having a stroke, or if the patient has PRES, the posterior reversible encephalopathy syndrome. if you have end organ damage of the heart, so you're having an MI or you have SCAPE, the flash pulmonary edema. If end organ damages of the aorta, like you're having an aortic dissection, or if you're having an acute kidney injury, your end organ damages via your kidneys. And then the retina as well is one that we think of.
Yeah, we often forget about that one.
Management. What's your game plan when you find that the patient's having the end organ damage here?
Yeah, so there's this classic teaching. They say you have to lower it by like 20 to 25% the first hour, and then the rest of it over 24 hours, whatever jazz. All that's been proven in studies to be pretty false. Like in general, if you're have someone critically ill, you should just lower it quickly. On the test, they still may practice this pattern, but I don't see a situation where the test is going to have to give you some type of question to describe how to lower the blood pressure. The IV meds in general, what are your go-to meds? What are your top 3 IV meds here for, in general, hypertensive emergency? I feel like one is more neuro-related, one is more general use, and then one is just aortic.
Yeah. Aortic. I think that's the easiest one to start with.
It is.
Yeah, Esmolol. We love
the MVP.
Esmolol.
Yeah.
MVP. Rapidon. First line for aortic dissection. And then a close relative of Esmolol is another beta blocker, labetalol. Good for neuro cases. You probably use this in stroke when you need to lower the blood pressure there. And then there's the clofidipine, nicardipine, which is also, I think, pretty commonly used for like head bleeds. It's pretty easy to titrate, not as quick off as like Esmolol, but is also pretty easy to titrate, and it's a drip medication as well.
Sure.
What do you hate?
What do we hate? I hate hydralazine. I have appeared on other podcast shows, and I've also spoken at conferences talking about how much I hate hydralazine. I just hate it. It's awful. It's not titratable. It has no predictable course. Studies have shown that it like lasts up to several hours. It doesn't do anything predictable. It's an awful medication. Please, please, please do not ever give IV hydralazine. It's so awful. You just don't know what you're doing when you give it. You will never get a titratable response.
Yeah.
Anyway, that is what you should not be using. That's the main thing. Labetalol should be your go-to if you're doing kind of that one punch, one dose. And then the drip for neuro, anything neuro is clofidipine, nicardipine, and then anything aortic is Esmolol. So we talked about the cases that need high blood pressure control. I would say the dissection is probably the most classic, true example of needing rapid blood pressure response. We get into the particulars here on the Rapid Bombs podcast of which strokes need to be acutely lowered. Intracranial bleeds, ischemic strokes, they follow their own pattern. We cover preeclampsia and eclampsia on our podcast. We cover SCAPE as well, the flash pulmonary edema related to hypertensive heart disease. We cover all this stuff. So we're not going to go into the doses here. We also have a handout on our website discussing the doses, discussing the levels and what your target numbers are. So let's just get into the key takeaways here that you need to know about.
They're not all the same. You can't just remember one thing. It's not just 20% reduction for all of these things. Exactly
right. There's a range you should be shooting for. Exactly right. So what are the key takeaways from this?
Key takeaways here. Hypertensive urgency is not a real emergency. Stop freaking out. Tell your patients to stop freaking out. This is one of my like little canned talks that I just have for the patient where I walk in the room and I open my mouth and I black out and this beautiful speech comes out and the patient feels
birds
better.
Sing.
And birds sing and Snow White enters the room and everything's great. Yeah. Aggressively lowering blood pressure in your asymptomatic patients is a bad idea, which is a part of my little talk. I tell patients, I'd be a terrible doctor if I just gave you a medication through the IV and gave you a stroke, wouldn't I? And they're like, yes.
I like how you reflexively on the video use your hand to touch your pearls, to clutch your pearls.
Oh my gosh.
Oh my God.
It's terrible.
If you're on the YouTubes, check us out. But the theatrics are worth it. Cool. What else?
Hypertensive emergency is a blood pressure reading plus end organ damage. It's not just the number. And you have to figure out what the end organ damage is if you're going to use that diagnosis.
Exactly.
And treatment of that depends on the underlying condition, not just the blood pressure, like we just talked about. And what's the last point?
Yeah, I like how you give it to me. No hydralazine. Don't ever do it. Hydralazine is awful. Stop. Doesn't do anything. I promise you will notice no change in your practice if you stop using it. As in, no effects will be missed. Cool. True. I think that's everything. So check out Rapid Bombs again. We cover the key blood pressure levels here, what your targets are, all these key conditions we talk about, the nuances of managing hypertensive emergency, the end organ damage, etc. So check out EM Rapid Bombs. How do you check out EM Rapid Bombs? You go to our website, emboardbombs.com. Check us out on the socials. Links will go directly to the Question Bank podcast. It's the only one in the world. Over 489 episodes, just posted one this morning. Pretty exciting things. We offer residency discounts.
Yeah, and if you're getting to the end of like studying for your ITE and you just like can't handle doing another day of online question banks and you just need to lay in the grass and listen to something, sign up for a day for free for EM Rapid Bombs.
Yeah, free trial.
Stream some of the podcasts, fall in love with it, and go from there.
Yes, hear the birds sing. All right, we'll catch you next time. Thanks again. Good to see you, Marlena.
All right.